Thank you, Dr. Ng, Dr. Afika, for the great sessions about creating the awareness on how to help this group, people who is in need. So next, second sessions is from the pediatric departments. I'm Dr. Chuah, pediatric intensivist from the pediatric departments, and today's it's my great honor to introduce our speaker, Dr. Chee Shan. She is our pediatric intensivist in UMMC, and she is our graduates from UMMC and followed that pursue her trainings in University Malaya too. And she just came back from Birmingham Hospitals, UK. And please, I would like to welcome Dr. Chee for sharing some topics about the simulation trainings. So, Dr. Chee, the floor is yours.
Thank you very much, Dr. Chua, for the very kind introduction. Good morning, everyone. I'm Dr. Chee, pediatrician from Pediatric Department, and today I'll be talking on something that is quite different from what Dr. Ikas has talked about earlier. And the title of my talk today will be on scheme to team, leveraging human factors and team dynamics via simulation training. Just a moment, yeah. Okay, so first of all, I believe the term a team is no longer foreign to any of us, as most of us as a healthcare workers are required to work in a team, which is defined as a group of people working together towards a shared or a common goal. And what is scheme to team? It's basically focused on identifying factors that make good multidisciplinary pediatric resuscitation team to form an effective high-performance team through integration of human factors via simulation training. And team dynamic is defined by behavioral, psychological, and social interaction that take place among team members. And why are team dynamics important? So team dynamics is something really vital in healthcare and resuscitation because there are often multiple teams working together in a resuscitation. And as we all know, it can happen in various settings, including the emergency department, in the pediatric ICU, neonatal ICU, in a general pediatric ward, or even in the operating theater. And for every one of us who have attended a resuscitation before, we all knew that there are often multiple healthcare personnel of different seniority and different background present together, and that can include, the intensivists, the anesthetists, the pediatrician, emergency physician, and any members of other teams, nurses, and our postgraduate doctors in trainings. And without a good team dynamics, a resuscitation can be a total chaos. So what constitutes a good resuscitation team? There are several aspects of a good resuscitation team, which include things like good communication and role clarity, good leadership and followership, situational awareness, high performance team, which are task and goal oriented, and lastly, maintaining civility. So when we talk about communication, what are important aspects that actually contribute to a good communication? First of all, is a practice of a closed-loop communication, and I believe this is not something new to many of us. However, this is not being practiced very frequently in our day-to-day practice. And this involves actually the sender initiating a message addressing the name of the receiver, giving a clear instruction, followed by the receiver actually acknowledging the message by repeating the message, and the sender verifies the message. Besides that, the second important aspect will be escalation. And in a resuscitation event, we often want an important message to be communicated, across. And sometimes, time is the essence, and we need to quickly communicate an important message without coming across as being rude or being aggressive. And this can be especially challenging if we are communicating with someone across the authority or power gradient. And how can we do this respectfully and effectively, ensuring that our words have the intended impact? So one of the ways is, to use what we call as a graded assertiveness. And there are actually various ways, various model of graded assertiveness. And one of my preferred model will be using the PACE model, which stands for probe, alert, challenge, and emergency. And this PACE model is actually something that is firstly deployed in aviation, And it is particularly helpful when there is actually a perceived hierarchy in place during a resuscitation. And PACE allow us to begin with a low-threat question, a pro, which may be well enough actually to cause the recipient to pause and to consider and adjust the course of action. And if it's not, then we can incrementally escalate to a higher level of assertiveness and urgency. Okay, the next important aspect will be role clarity. And it's really important for each and every one of us as team member to be clear about our role and responsibility. And in a resuscitation involving multidisciplinary team, sometimes it will be really helpful for the team members to have the name and to have the position and also role on their uniform or scrubs. Besides that, another important aspect that I would like to stress on to provide good communication will be a shared mental model. And shared mental model is basically a shared understanding of the goal of the team, the individual team member tasks, and how all the team members will coordinate to achieve their common goal. And in a resuscitation situation, the team leader should always ensure there is a shared mental model among all the team members on the problem and the goal. And this can often be achieved by having a regroup or a pause during a resuscitation if things doesn't go right. Lastly, it is also important to address all the barriers in communication, and this will include things like physical and environmental barriers, okay, where there is noise and there's personal protective equipment, psychological barriers such as a perceived hierarchy, and cultural or language barrier that potentially can impede on a very good, effective and effective communication. So how do we ensure good communication during a resuscitation? One of the measures to aid in a good and effective communication will be to have a team briefing if the situation and time allows. And in a team briefing, all the team members should be made aware of the common goal and the situation that the team will potentially be handling. And the plans should be then laid out, and each member should be clear about their roles and responsibility. And it is also vital for everyone in the team to be aware that what can potentially go wrong, how will we know, and what do we do when things go wrong. The second important aspect of good resuscitation is to have good leadership and followership. And in order to be a good leader, one must first become a good follower, as stated by Aristotle. Another important famous quote by John Maxwell saying that a leader is one who knows the way, goes the way, and shows the way. And this implies that a good leader should have a good clarity of the goals, strategies, and challenges, and he or she should lead by example and guide and empower the team. So what are the important leadership skills? I believe we were all taught about all the technical skills such as history taking, physical examination, and procedural skills in our medical school and also in our postgraduate training. However, the non-technical skills are actually equally important in ensuring good leadership and also good team performance. And these non-technical skills are actually cognitive, behavioral, and social skills that contribute to efficient team performance. And these include things like situational awareness, task management, prioritization skills, and also decision making. Other than that, to be a good leader, okay, there should be a shallow authority gradient and inclusive leadership whereby all the team members should be allowed to voice out the concerns and also their suggestion during a resuscitation. And lastly, it is important to have a transition of leadership if there is a change in leadership during the resuscitation, especially if the leader is required to take out another task. And moving on, the next aspect of a good resuscitation will be having a situational awareness. And situational awareness is a dynamic process of perceiving cues that in the environment, understanding what they mean, and predicting how the situation may evolve. As you can see in this picture, the team leader almost always position himself or herself at the end of the bed, with the scribe, being positioned standing beside the team leader. And this is allow a better situational awareness. It's also important to be aware that time is critical in a resuscitation, and having a scribe person to be a timekeeper will be important in any of the resuscitation. Besides that, what are the traits that can prevent good situational awareness? So tunnel vision, and also being task focused is something that is commonly happen during a resuscitation, and thus it is important for the team leader not to be occupied with a specific task and able to have like a helicopter view or overview of the entire situation. And other than that, adrenaline rush and cognitive overload are potential factors that can prevent good situational awareness. Next is having a high performance team. And what is a high performing team? It composed of individuals with specialized expertise and complementary skills that are goal oriented, hyper focused on achieving clear and outstanding results. And if you can see from this figure, this is a features of all the effective team performance that we have talked about. And if all this behavior of an effective team are independently practiced and honed to efficiency, the marginal gains of each and every one of these will then cumulatively actually contribute to overall performance of a team. And if you look at this dial-shaped curve, okay, you can see that this is actually a curve showing that the performance of an individual actually depends on the stress and the arousal level. And in order to have an optimal performance, we have to have some stress, not too much. So optimal stress and optimal arousal level. And if there is too much stress or stress overload, and also there is a increased arousal level whereby there's anxiety, anger, that can all cause an impact in the performance. Another things that I would like to highlight in my presentation today is about human factors. So the optimal performance of a team will be influenced by human factors affecting every members of the team, and that includes the physiology and how well they are, the psychology, the interpersonal relationships, the environment and surrounding, and of course, proper functioning of equipments and technology. And you see from this figure, if there is any presence of all these human factors, okay, the performance of an individual can be affected even though the workload is the same. And every single members of the team should also have this health bucket self-assessment being performed. As we all know, if we're hungry, we're angry, late or tired, there is always a higher tendency for us to make mistakes and error. And if you have a full bucket at the beginning of the day, that is actually, you need to recognize that there's a high risk, for you to perform mistake and error. It can look like something really simple, but often enough, to cause human errors. Lastly, maintaining civility at workplace is very important, as civil work environment actually reduce error, reduce stress, and foster excellence. And when we talk about civility, incivility, this can actually range for, a simple behavior like eye rolling, sarcastic comments, to aggressive and violence behavior. And how many of us actually has experienced this in our working environment? Have you actually witnessed any rudeness at work and feel humiliated, ashamed at work? And in my opinion, actually, there is still lack of emphasis on civility in our working culture and also environment. And we all need to realize that how we treat each other at work actually has an enormous impact on how the team perform. And we can only form an effective, high-performing team when we treat each other well. So if you look at this, a civil clinician can actually evolve into an incivil clinician with the presence of external stressor and also with a permissive environment. And if you look at the Civility Safe Life website, okay, when someone actually is rude, okay, it actually affects, people surrounding as well. And 40% of the people actually has reduced quality of their work, and near to 50% actually has reduced time at work when someone is rude. And less effective clinician provide poorer care. And we need to know that incivility also affects everyone around. And you can see here that for someone who witnessed an incivility, 20% actually decrease in performance and near to 50% decrease in the willingness to actually help others. Okay, so this is a TED Talk by Dr. Chris Turner, and Dr. Chris Turner is actually a consultant in emergency medicine in University Hospital of Coventry in UK, who shared about how rudeness at workplace can actually cause fatal consequences. And I'm sharing this because I found this a very enlightening talk, and will encourage every one of you to listen to it. And it really highlights the importance of maintaining civility at work. So we have talked about all the important aspects of a good and effective resuscitation team, but how do we actually ensure this is actually being achieved in our clinical setting? So one of the ways that have been proven to be effective in improving team performance is from via simulation-based learning. Simulation-based learning is one of the main components of healthcare education, which I believe actually has proliferated tremendously in the last few decades. And many healthcare institutes now around the world has actually adopted simulation as a learning tool for skill acquisition and for decision making through real-life situational experience without needing to compromise patient care and patient safety. And the example of common types of simulation-based learning in healthcare include things like a mannequin-based simulation, whereby we can have high fidelity and low fidelity mannequins. And fidelity in simulation actually refers to the degree of realism a simulation provides in replicating real clinical scenarios. And when we talk about high fidelity mannequins, they can actually stimulate physiological response like the breathing, heart rate, pupillary response, and even speech and cry. It enables a dynamic interaction and also a real-time feedback based on the learner actions. Low fidelity mannequins, on the other hand, has limited interactivity, and they are often used as for isolated task training purpose. For example, skill training in IV line insertion, in intubations, and also in suturing. And the other types of simulation is about task trainer simulation that we talk about, focusing on the task or skill training, and hybrid simulation, which is a simulation that is involving multidisciplinary teams, such as a major trauma simulation. And this figure, shows the Miller pyramids of clinical competence, which actually show the concept of simulation, whereby we started off having the theoretical knowledge, and then we observe, people that are having the skill to perform the skills, and then we also use simulated training in order to train certain skills, and lastly, practice it and performing in a real case after a multiple practice. So in Birmingham Children's Hospital, where I received my training for my pediatric intensive care, I was actually very fortunate to be able to take up the role of a simulation fellow to work together with the simulation team there. And we run a twice monthly unit simulation and various simulation-based courses such as the stabilization day and regional acute pediatric training course, whereby we actually perform a simulation training for multidisciplinary team in the district general hospital as well. So the simulation is actually for multiple teams like the surgical team, the anesthetic, and also emergency physician, and the pediatric team. And the simulation is actually being designed according to the needs of the team. So this simulation is performed using high fidelity mannequins, where you can actually treat the mannequins like a real child, like you can administrate fluids, give medication, perform CPR, and so on with a real-time feedback. And this actually provides a safe space and psychological safety for training without compromising patient care. And we're also very fortunate to be able to have to provide video debriefing after each simulation session. And I find this session really useful, whereby the simulation sessions or training are being video recorded for education and learning purpose and for debriefing purpose. So after each of the simulation training, we will give a debriefing based on the aid of the video recording. So in our PICU and our center, we have not run any simulation course. However, we actually run a few other courses which incorporated simulation-based learning. And one of it is our pediatric advanced life support courses, whereby we incorporated simulation-based learning for our pediatric postgraduate trainees, the house officers, nurses, and also colleagues from other departments such as our ED department, dental, and surgical, and so on. And we also started running some simulation training for our pediatric master student during their rotation to pediatric ICU. As you can see from this photo, they actually practice, having ultrasound guided vascular access course, vascular access practice, and also running simulation for common pediatric emergencies kind of situation. And there was also a request for us to sort of run some simulation training for our colleagues and nurses in our pediatric operating room, which we are still trying to work and lining it up. So moving forward, I think we should really advocate a simulation culture, and we should incorporate simulation-based learning in our day-to-day work. And looking at how simulation has actually evolved over time and the importance of simulation in healthcare education, we should increase the emphasis on simulation training. And this can be achieved by having a simulation team with staff that are trained in running regular pediatric simulation and debriefing. And I find that video debriefing is definitely something that is really valuable aspect of a simulation training. So we've started on, having some simulation sessions for all our trainees in the department when they come to pediatric ICU. And moving forward, we hope that, slowly we will have more resources and more manpower to run more simulation training. So the take-home message for my presentation today is simulation-based learning is essential in healthcare education, and it plays an important role in improving team dynamics and addressing human factors to form an effective and high-performance team. And this is important to improve healthcare staff confidence and their competency in dealing with emergency, and ultimately, hopefully, we can improve patient outcome. And one other message that I really want to get across is it is important for us to realize that human factors can affect team performance, and it is also really important for us to maintain civility at workplace. And before I end my presentation, I would like to acknowledge Dr. Fajif Habib, who is a consultant pediatric intensivist and simulation lead in pediatric ICU and in the Birmingham Children's Hospital, UK, which I have the privilege to work with. I would like to acknowledge him for his some of these picture that I put on in our PowerPoint slides. And Dr. Fajif is now actually a consultant pediatric intensivist in Abu Dhabi. So together, everyone achieve more. That's the end of my presentation. And thank you for your attention. And I welcome any question. Thank you.
Thank you, Dr. Chee, for the wonderful presentations about this simulation trainings. This is all the challenges we are facing throughout to implement this the simulation trainings. So actually, we are improving step by step to implement more and more this simulation trainings daily care. So I think we have a few questions from the chat box. So I think number one question is from this Dr. Chan. So you'd like to know that how far do you think that we are from achieving the ideal team arrangement that you described? Challenging question. Yeah.
So yes, thank you, Dr. Aki Chan, for the questions. Okay, yeah, indeed, a very challenging question. So I think we are actually moving, on to perform more simulation from many years earlier when I was actually a house officer and also a MOs. I think we do not pay so much sort of emphasis on simulation. And nowadays, at least, for the pediatric department, for the medical officers that come through our pediatric ICU posting, we also realize that they might not have so much of opportunity for hands-on, and we try to incorporate more simulation kind of learning for them, including having practice in ultrasound guidance, vascular access, video laryngoscope intubation, and running some common scenarios. And I think this is something that can be done, not just in the ICU itself, and also we can do it in the pediatric ED department and so on. And so, of course, we need manpowers and more manpowers and people who are trained. And this is not something that can be done in a short duration. And even for, each and every one of us in the intensive care, we need to receive, specific training in terms of how to do a proper simulation and debriefing before we can go on, to have a team to do that. Yeah.
I also would like to thanks to Dr. Chan about mentioning the importance of senior role models in the showing the humility in their leaderships. I think in these simulation trainings or real resuscitations, high performance team situation, I think this role models and showing the humility in their leadership is very important, because regardless of positions, each person you reach play the role and then to to reach the goal that we want to achieve. So next is, I think got a couple of questions. Some more is Dr. Sarah. Okay. So regarding team role briefings, should ICUs have these talks daily and perhaps the normal wards weekly? I mean, whether we have any daily activities on this team role briefings.
Team role briefings. Okay, so for the pediatric ICU, actually, no, we actually have some sort of like a team role briefing, and what we normally do for our MOs is, on the morning, on the start of the day, we actually tell them, we want to identify who are the team members that are working, including, the amount of nurses that are working on the particular day and the amount of patients, and what are the sort of things that we anticipate will go on for the day, including like the numbers of bookings, the number of patients that are not going to come in, who are the patients that we identify can be discharged. And that is also some sort of like a team role briefing for, the work. And for resuscitation situation, okay, we also try to actually have some sort of briefing whereby, the team leaders normally assign the roles before we start on, and, we talk about what are the things that we are concerned about a particular patient, and what are the things that we anticipate can go wrong, and what to do, if it goes wrong. And this is something that I think we try to do in resuscitation situation if times allow, or even, in an elective kind of like an intubation situation, we always try to have some form of a team briefing before we start. But of course, sometimes, resuscitation can be emergency, and, we won't have time to do a team briefing. But it's always important for, any of the experienced team leader to be able to, find some time to regroup the team during the resuscitation, to ensure that, everybody is in the same page when we do a resuscitation.
I have a last question from Prof. David regarding states. Questions: how would embed this in the undergraduate program?
So I believe, there are some work going on for the simulation in the undergraduate students, and we have a simulation lab actually here. And I believe, some of the team members, the anesthetists and intensivists, they're also running some simulation program for our undergraduate students. So it is sort of like, there is something moving on, but we might need to have something that is more solid, like, a proper program with regards to simulation in the undergraduate for the undergraduate students. But yeah, definitely I believe that, the undergraduate student nowadays do receive some simulation training, and we have a simulation lab in, our UMMC to actually assist in that. Yeah.
Yeah, I think we are near to 9. Okay. I think we could conclude this breakfast UMHealth breakfast sessions. Thank you very much, Dr. Chee, for sharing with us about these simulation trainings. Hope that we will progress more in the futures and have a better trainings for everybody and the team members. Okay. Thank you very much, everybody.
Thank you very much. Thank you.